All right. Hey, everyone. How's it going? Welcome to another edition of the Stay at Home Learn with Us webinars here from us at the Turquoise Study Club. Just a bit of housekeeping. We apologize, but due to some unfortunate circumstances, our regular program, Bilal, was not able to go on. We wish everyone all the best, and we hope to have him back. In the interim, you're stuck with us. So the three of us, and I'd like to introduce my host, Serhat. How are you doing today?
I'm fine, thank you, Arthur. And how are you,
I'm doing
Pantelis?
well, thank you. And Pantelis, how are you doing?
Hey everybody, I'm fine. I hope the same for you too, and the viewers as well.
So today we're going to do something kind of on the fly. It was a topic that we received some questions about, and we figured, well, if I have Serhat and Pantelis, two of the smartest minds in dentistry here, maybe we can talk a little bit about posterior composites. So what we're going to do for today's session, as they're laughing behind me, is we're going to have brief presentations from the three of us, and then we're going to be happy to ask any to answer any questions you have, any comments, any concerns. Maybe we can help with any of your clinical questions. So to get us started, Serhat is now going to give a brief presentation on how he treats the posterior class 2 direct composite restoration. Serhat, it's yours.
So I need to check the other screen because now I'm the moderator for this presentation. For that reason, I need to select the correct screen on my mobile. Just 1 second.
How many computers do you have open?
No, it's fine. It's okay. So you will be on the left-hand side, and please watch the comments. So I cannot read the comments right now, okay?
Go for it.
So you talked already that the lecture will be interactive. So they can immediately ask the question, so we can respond the question right during the lecture. Is that right, Pantelis?
Yeah. Anybody who has any questions on what we present, he may interrupt. We will address the questions at the time, not at the end of the presentation as usually.
Okay. So I proceed, and I will check my.
So Serhat, the podium is yours now. Okay.
Okay. So you see my front page? Started?
Yes, go right ahead.
Go ahead.
Okay. There is a delay on the Facebook. Okay. So now I will talk about some small restorations which are done in posterior region, which are in fact small class 1 and class 2, actually class 2 restorations. And I will talk just a bit about adhesive materials we are using for the direct restorations. So we have the composite material, but not only the resin that we are using, the viscose one or the flowable, but also the bonding agents we need to use, because we have the enamel and dental substrates. So we want to be sure about the quality of the adhesion that we are doing on the right direct restoration. So when we are doing this direct restoration, we need to be sure that the quality is improved using the some skilled techniques like doing the correct moisture control. The best is for sure rubber dam isolation. And after all, we have to obey the correct instructions of the manufacturer. So if we have a material like for example, universal adhesive for the hybrid layer, we need to obey, we need to use all the rules that are given, all the instructions from the manufacturer. So any failure is not available because of the mistakenly done procedures. So do you have any questions on the right-hand side, Pantelis? Right now? No.
Go ahead.
Okay, so people may ask questions if needed. And we have the composite material, and they are named maybe because of the amount of fillers or the filler loads or the filler size. So we have lots of options in the market right now. like the macrofield, small particle, hybrid, microfield, or non-hybrid, etc. And we have also, according to the Fillerland, the for example, in the flowables that we are using usually for the posterior, the most popular ones, the highly filled flowables. And the composite material is something like that we are using for restoring for the cavities in the posterior region are mainly in this structure. The fillers inside within the resin matrix. So also there are silicon coupling agents surrounded for these fillers. And so the substrate is another issue, but here I only have the slide for the dentin. And thanks to Prof. Ferrari in Siena, I had chance to improve my laboratory skills in Siena in last 3 years, and I had these nice images myself. So as you see here in the left-hand side, we have a different kind of dentin, and the second one is sclerotic dentin. The left one is a dentin which looks normal, but the second one is sclerotic, that we have the closure of the tubules where we might not have the chance to have some resin tags within these tubules. So sometimes we are that close to pulp, vital tissues, like in the third one, and we have in the electron microscope image, we have the odontoblastic processes. So we have a very, very difficult substrate, which is called dentin in compared to enamel. So we need to be sure about the quality of adhesion. So rubber dam is preferred and to have this control during this process. And the use of dental composites for the small or middle-sized class 1 and class 2 restorations are really indicated. When we have the larger ones, like these examples, it's a little bit difficult. And we know that the most common reason could be the polymerization shrinkage factor because of the material shrinks while we restore the tooth. So maybe it's better to use not direct and indirect, but sometimes we know that some methods could be advantageous to decrease the amount of this risk. So two favorite one. I would recommend incremental layering or the low light intensity curing lights, like a soft start or a pulse lay, just to minimize the effect of polymerization shrinkage. But mainly, whenever I'm doing a posterior restoration, I will go for layering in incremental, even less than 1 millimeter sometimes when I'm so deep and when I'm restoring a huge, large restoration. So this failure, because of the polymerization shrinkage, may result some problems. And because in the marginal adaptation of the adhesive interfaces of the restoration, there could be a micro leakage or a fracture. And clinically, this micro leakage problem could arise as post-operative sensitivity or marginal staining or secondary caries. And we are all familiar for these terms. So I will show you some clinical examples. The first one is class 2 cavity. In this situation, I'm so lucky that I don't have an adjacent tooth, so I'm not worried about creating a contact. So, but in this case, I tried to make a nice rubber dam isolation, where I did not use a clamp for the restored tooth. So I tried to use a dental floss for that reason, just to increase the visibility, just to have a nice view for my restoring area. So in the second photo and the first photo, you can clearly see that it's not a big problem for the operator after this. So rubber dam is stabilized using the bonded flows technique, like the bonding material, or you can use a small piece of flowable and light cure it, so you have stabilized flows around the tooth. So the rubber dam will not interfere with your restoration. And after that, you can easily clean and shape the margins, and you can work in the area without any problem. Like you don't have the interference of the tongue, lip, or the anything coming from mouth. So you're not worried about blood or saliva contamination, just in this case. So here I do selective etching because with skipping is not my preference. I always etch enamel, whether I'm using a universal or the self-etch bond, because I know that if I don't etch enamel, I might see some staining, and I know that it's better. I might see some staining in the margins of my direct restoration. So for this reason, I'm always etching enamel. And now you see application of universal adhesive, and the color is a little bit yellowish, which is nice. So you see that I just apply and wait for a while according to the instructions of the company. If the company says 10 seconds, I just let it stay at least 10 seconds. But if the company says to scrub, to you apply with the scrubbing motion, I scrub. But if the company says just to apply gently, I obey the instructions. Otherwise, I might see this could be a reason for the failure. On the right-hand side, you see...
Serhat, we have a question.
Yeah, please.
Okay. So, excuse me, but it is the mode. Yeah, we have to interrupt each other when we have the questions. So,
Yes, okay.
okay, the question is, could you please talk a little bit about the low light and its connection to low shrinkage? What wavelength are we talking about and what times?
I need to go that paper because I used the references in my slide. And in those references, when we go to the paper, it's well discussed in the paper. But we have not only that option, other options. But I cannot name exact numbers for about these measurements. So,
okay, so we're going to elaborate this next. Okay, thank you.
Okay.
Let's go ahead.
But this is a very specific question. In order to answer this question, maybe we can request a lecture from a friend, because this is a nice topic to discuss. Because some people are interested to use the light cure device in a very fast mode, like they believe that they can light cure a composite material in 3 seconds, 5 seconds. But it's not my preference, because I want to avoid the risks of polymerization shrinkage. So it's better to use in low.
If I may add some comment with this,
yeah,
it's not actually the intensity, the initial intensity that plays role with for the proper polymerization, but anybody has to know which is the photo initiator that is contained inside his materials. Because
I think it's photo initiator. Okay, yes, exactly.
Yeah, because
it should be it should be the suitable photo initiator for the light. Yes.
Different materials have different photo initiators which are working in a different wavelength. So if you, for example, have a camphor quinone, okay, this is polymerized at 480 nanometers. But if you're, example, using, let's say, a bulk fill from Ivoclar, which has the ivoserine inside, then it's polymerized at 405 nanometers. So this could be not working with your wavelength of your lamp. So you have to know not just the intensity, but the intensity on the specific wavelength that your material contains. So then you have to adjust the time according to the intensity on that wavelength in exact. Okay, I don't know if Arthur, was I specific enough?
That was very clear. So yes, absolutely.
Okay.
Now, I just want to say before we start, Alexnia, the question that you asked, and I'll just read it, is: Doctor, would you advocate a routine use of glass fibers or polyethylene fibers, such as Ribond, in cases where you use direct composite in extensive cavity? Now, I will just ask that I can almost guarantee you that question will be answered, but just not yet, because we have something very big coming up from Dr. Pantelis. Is that correct? So is that okay? A little teaser?
Yeah, I will probably give some information about the questions. Okay, yeah.
Okay.
Yeah.
So, go ahead, Serhat.
Okay. So after the second one, you don't see the bonding material, which is, I mean, very thin, because here it was air blown, so the thickness was so less, so you don't see any movement of the fluid on the surface, because this is the universal material, universal bonding agent from GC, and GC recommends to apply 10 seconds of maximum air pressure. And maybe it's not suitable for the other company's product, because I know some other companies, even they are universal bonding material, they do not advise fully air blow for 5 to 10 seconds. We need to obey the instruction, but this should be done according to the guidance of the company. And after light curing, now application of the composite material. But here my preference was layering the higher chroma as a dentin shade below the enamel. The initial dentin after the secondary layer of the dentin. I would like to restore the tooth in a biomimetic approach, and then addition of enamel in small pieces. And finally it's restored, but not fully done, because only the margins are corrected and polished, but I'm not sure about the contacts. And here in this case, we have the clamp, so we cannot check the contact right now. After removal of the rubber dam and the flows and the clamp, we can check the contacts. Here you see the appearance of restoration. So do you have any questions right now, Pantelis? I will proceed because I don't see the other screen.
Yeah, let's go ahead. Let's proceed. Yeah.
This is the initial and this is the end. So this is just a small restoration for posterior region, and it's a vital tooth. And I'm so lucky because I had no just neighboring tooth to the restored tooth. So the second case is again a similar one, which is class 5, and I'm not able to show you all the steps of this drilling process, but I had to include some parts for the occlusal because the cavity was going to the occlusal direction. So I need to follow the caries lesion, not the. I don't have a certain shape for the cavity that I'm preparing for the posterior. So I'm just following the direction of the caries lesion here. And after drilling, I'm a little bit close to a pulp. I know because of the color, but I don't drill everything because I know that if I go so close, then I might have maybe we might have some problems because the composite material or anything that we are using have the cytotoxic effect. So maybe it's better. I know from the papers it's better not to remove all the cavity. This is a different approach, and you might see on this right-hand side the application of the circular matrix. In this circumstance, it's not a big deal because there is no contact. But when I have a contact, maybe it's in general I prefer using a sectional matrix, not a circular one. I prefer the sectional one usually.
Serhat,
And then, yes,
question.
please.
At this stage, if you check the contact and there is need to remove enamel layer for correction of high spot, what will you do? And at this stage, okay.
One. Yes, this one.
I think he
Yes.
was referring to this one. If you check the contact and there is need to remove enamel layer for correction of high spot, what will you do?
Generally, it's an interesting question. I think can you repeat the question, because is he asking if I have a problem about the margin, if the contact is in the margin between my tooth and the
I am
replacement?
supposing that he is referring to premature contacts, the occlusal contacts. If you have
It's
a high
usually
occlusal contact and you have to correct the occlusion, what would you do if you go on the biomimetic approach, if you go for layering?
okay. He's talking about if I'm removing the composite enamel, not the natural enamel. Is this
exactly. Yeah.
now it is this situation. I made it on purpose because I layered the dentin that large, so I want to see in the end, I want to show in the picture some abraded appearance because I made it on purpose. I won't add any extra enamel right now because I just want to make something like a worn tooth on this picture.
I have the
But if I
impression
have
that
to,
yeah,
if I have to add, remove and add, then it's yes, you can add, remove some material and add some different material. We can do it, but we need to clean there, and we need to sure about the moisture control again, and we need to apply. Universal bonding is a very thin one, so we may apply a bonding agent, and we might proceed. But we need to clean very well. Yes.
I'm under the impression that our friend is asking about when we are anatomically building up biomimetically a tooth, and then we do everything fine and everything beautiful, and then we have to actually correct the anatomy due to occlusal contacts. What's going on? I need to say that if you do this properly, you will not ever have any contacts inside the sulcuses, inside the fissures, and at the probably at the highest ends of the cusps. So you will probably see that the contacts, if you do this properly, the contacts are gonna be to the inclined surfaces of the cusps. So this is not gonna interfere with them in a big way to your primer anatomy that you have struggled to give. Okay, so I don't know if you agree to this comment.
I agree with you.
Arthur?
I completely agree with you.
All right, so maybe we should proceed, Serhat?
Okay. This is the cavity, but I need to say that it was in the beginning, it looked easy, but when you drill the cavity, you go a little bit cervically, means that the margin of the proximal margin is extending to the dangerous area that you might see, you might have some bleeding. So even under these circumstances, when you look clear after this drill, there is small bleeding around the rubber dam. So this is our common problem. We only show the perfect pictures, but we have sometimes, even under isolation, in some small areas, we need to increase the quality of the rubber dam closure. So even this is an heavy gauge rubber from Nikton. It was not that easy. So I use something extra, as you see there, the Teflon, just to have some blockage for the passage of the liquid from the wet part of the rubber dam. So sectional matrix, not the sectional, but circumferential matrix was applied. And now I can do etching and do then the application of bonding later. I use here heavy, highly filled flowable, which is my preference for restoring a posterior teeth. Today, we have the highly filled flowables, not the normal ones, and they restored well, and the wettability, especially on these proximals, are nice. But maybe some people may argue about their physical properties, and they might argue their low quality physical properties. But I think after now they will be much more popular in the market, because I see that many companies are having these highly filled flowables, and people are using often those products because they are really efficient, and you can do a restoration faster that you can imagine than when compared a viscose composite, because viscose composite is to me is a bit difficult, and just because I like the I mean it's really handy when you use the highly filled flow. Just because of that, it's my preference. And this is after with one monoshade layering of the posterior restoration. But thanks to Teflons, in addition to rubber dam, it worked well. And you see in the mirrored image, I had a nice, not bad margins. And after I removed Teflon, you can now realize, you can now see the bleeding from the gingival area. So without the rubber dam, maybe I could not block that easy. Yes, we know the other ways, like using retraction cords. Others could be we have other options to stop this bleeding. And this is the final case that I will present. It was a premolar for the upper. It was an upper premolar that I restored years ago. Today, I would not restore in direct approach, but I did it. And I follow this case. I don't know if I have the poster, because I placed an implant on for the second premolar area. And this was a nice restoration. And after removal of the amalgam and placement of the circumferential matrix, and then application of the viscose composite this time. At that time, I was not using the highly filled flowables, so I've tried to restore with, but you may see that the margins are not that perfect. You see in the proximal margins some bluish color, but I was not worried, because I have the chance for, I was sure about moisture controls, but I know that there will be some excess of the material, but I could correct it because there was no problem. There was no place to wedge my matrix, and I had no chance at that time for closing the gap while layering. But in the end, I corrected everything freehand with a disc or some scalers. So layering the proximal wall, and after finalizing the proximal wall, I could layer the fiber reinforced composite in order to increase the strength of the overall restoration. It's just decreasing the chance of the fracture or the crack formation of the restoration. So a secondary layer for the average posterior, which is fiber reinforced composite material, and finally a masking liner just to increase the opacity, because these fibers are fiber reinforced composites are a little bit grayish. If you don't color with a masking liner, then you might see a grayish effect. So I just use a masking layer and the dentine shade, and this is actually not a dentine shade, it's a body shade, and completed the cavity, and finally finished and polished. And this was my work at that time, which was maybe 4 or 5 years ago. And that's it today that I will show, because I think Pantelis will have some nice cases for us. Can you proceed,
Thank you very much, Serhat, for your beautiful presentation and the addressing of the questions. I think we should pass the word to Arthur to present us more minimal invasive, but which actually are not quite simple as they appear to be if you think something minimal. But Arthur, please.
Sure. Okay. So thank you, Serhat. Thank you so much for that fantastic presentation. So let me just get here. Let me do my application. Okay. So I do want to thank everybody for your comments after the presentation that was done that I did the first time with injection molding. And I received a lot of questions about, well, what do we do in the posterior? Because I know, especially outside of the States, that there is a lot of people using the Class 2 system for injection molding in several applications. Guys, am I on? We're good?
Yeah.
On? Okay,
Yeah,
thank you.
Arthur, just give me a second, please, because we have some questions. Serhat, isn't ceramic only better for this case? I suppose that he means
For
the last
sure.
one that you showed.
For sure. For
Okay.
sure. It's a premolar and it's a huge restoration. But my intention was just to minimize the risk of the direct approach. So I used something like glass fiber reinforced composite. But for sure, an indirect is a better option.
So
No
you
doubts.
actually have already answered the next question, which is asking, is polymerization shrinkage less in fiber reinforced composite? Yes, is the answer.
If you don't layer in smaller increments, then you will have the same. So I think I don't believe that the bulk materials can not minimize the shrinkage. Only you are sure that you have the polymerization below. But what do you think, Pantelis?
I will disagree with this because they have a different chemistry inside. They have bigger polymer chains, pre-polymerized chains.
But do you believe that you can? Yes, I understand. But
Yeah.
would you polymerize them in 4 or 5 millimeters?
Actually, there are some literature works on those. There are some that can be polymerized up to 4 millimeters adequately.
Okay, I would like to have the references, please.
Yeah. Okay.
Yeah.
And
I'm sorry.
Pantelis, does that include bulk fill as well?
Yeah, we're talking about bulk fill, only bulk fill. Okay.
But
There's
what
some bulk
about the
fills
studies
which-
are done for all the bulk fill materials in the market, or only few of them?
Exactly.
For all of them?
No, actually, studies are done for the most of the bulk fill. Actually, the not over the counter manufacturers. Okay, so most known manufacturers have we have studies for those materials. There are some
But what
which
about, can we generalize it for all the materials in the market?
I don't know. I don't know about any studies for the over the counter materials. I don't know about it. So,
But some of them are.
yeah. Okay. So we're talking about the original manufacturers, which actually are applying new technologies for their materials. Okay. So some companies are appearing to be relating the bulk filling approach with the dual curing approach. So they're creating some bulk fills which actually are not just photopolymerizing, they're chemically polymerizing as well. Okay, so we're actually a long way to go into this subject, but yes, we have some bulk fills which are demonstrating that can be polymerized up to 4 millimeters. The main disadvantage is that they're too translucent. This is because they want to allow the light to pass through the bulk from the material and reach to the 4 millimeters. So they're too translucent and they're not aesthetically pleasing at all. Okay, but we have less strength, polymerization strength, and less compressive strength.
But what happens if you just layer in smaller increments for this even bulk layer? Then you will be always in the safe side.
You can do so. Yeah, you can do so.
So
Yeah,
the best
course.
is always to layer maybe in smaller increments, even you're
Yeah,
using bio.
I would say so. And the best is to over polymerize any photopolymerizing material.
And if it's in the deep section of the cavity,
Even
by the
more,
way.
even more, even more.
Even more.
Okay, so, excuse me, Arthur. We consumed more of your time, so
Oh, that's fine. I'm only going to
Go
make
ahead.
one. I knew this would happen. Once you guys got going, I knew it was going to be
So
good. But I think I'm going to give some people a heart attack, which is probably my intention with what I'm going to show next. So hopefully it can make some controversy like the first one did. Just tell me when I can go.
let's go.
Okay. Okay. So what I'm just going to show with this one case is how we do a step-by-step approach using the injection molded technique. So the first thing we do, of course, is to touch what Serhat said, is that we always use isolation, but I'm going to show something a little bit different, how I approach it. What you're looking at here is a case we're going to do 2 back-to-back or adjacent class 2 restorations. So whenever we're using the BioClear system with injection molding, the first step that a lot of people, be it our students or when I see presented, is that the first thing you should do is you should first do something we call a pre-wedge. So in this case, I'm using a wedge to impart some small degree of separation to the teeth before I've even started the preparation. Now, what you saw in the first slide was the rubber dam and everything fairly isolated. But in truth, especially in larger and deeper caries, I will actually start preparation without the rubber dam. And there's a few advantages. Serhat actually touched on one of them because you saw that in one of his cases there was bleeding, and so he went with the Teflon. To sometimes avoid this and deal with these types of scenarios from occurring initially, because I have a hard enough time to put on the rubber dam, is that I will go first and prepare my caries without any isolation, or maybe something like here with the Isolite or IsoDry. Because when we get down that deep, I have several options. I can use something like a laser to cause some hemostasis prior to putting the rubber dam. I can remove the papilla with the endo burr that was quite popular by the people from Tomorrow Tooth, where the actual papilla is simply removed, and then we can place the rubber dam. So just to reiterate, I actually prefer to do my initial preparation, especially on deep caries. In this case, I'm going to show you it's quite small, but I prefer to start without the rubber dam, with some matrix, with some wedging to create separation. But I actually prefer not to do the rubber dam at this time. But in this example, we did have the rubber dam because we saw it was quite small. So I'm going to make my initial preparation, and we're doing a saucer type shape to the preparation. So we use a flame diamond to achieve this. Now this is easy, and I'm not worried about the adjacent contact because I'm absolutely going to go through them. So my initial penetration of the burr is approximately 1.5 millimeters away from the marginal ridge, just simply because it can act like a guide when I'm preparing. Now, again, in this case, this doesn't matter because I'm going to go through the adjacent tooth anyway, but I prefer to start here. Then once I locate my caries, I'll go ahead and remove them, and I'll use the round carbide slow speed to remove it. And this is very standard, of course, across the board. But I want to get to this point, and this point was sort of brought up by several people, and that is this. When we do a class 2 restoration and we are trying to remove any type of biofilm or caries, we do a very good job of removing. We know how to use caries indicator. We know how to use tactile feedback. But in a case, if you're planning to do injection overmolding of teeth, and I'll show you what that looks like because it is going to be quite unusual. And I'm sure we will get a lot of questions about polymerization, shrinkage, and I will certainly defer those questions. And I'm very curious to what Serhat and Pantelis think about this. But that's when we're overmolding the tooth, we are actually going to wrap the composite across the buccal and lingual surfaces of the teeth. So in order to ensure that we get a good bond, same as we did in the anterior, we want to make sure that the posterior is clean. Why am I making a big deal? Well, because right here on this case, I'm going to place some disclosing solution. And when we rinse off the disclosing solution from this tooth, you can see where we still have quite a bit of biofilm left on the tooth. Now, again, in the technique that we are going to do, we are going to wrap the composite across the buccal and lingual proximal surfaces of the teeth. So as you can see, and I think an arrow is going to come now, you may see, we have quite a bit of biofilm along the proximal areas that were not touched by the burr. So if we were to directly bond to this current situation as it stands, we can say, okay, listen, the cavity is clean, there's no caries, but you have a lot of biofilm. So where will the bond most likely fail? And that will be on the buccal and lingual, because the concept here, and I will not go into it in detail, but is not to fill the box. We are not trying to fill the box. What we are trying to do is to fill the teeth. So this is what the situation looked like after we use some air abrasion. Now, at the very least, we know that I'm going to bond on tooth surfaces and not on any type of biofilm, which will definitely impede my bonding. So I just want to show that, because that's a big thing for those who are using the technique, that very often they'll remove the caries and immediately go to fill the restoration. And again, that's a very precarious thing to do, because you can, in fact, impede your success by doing so improperly. Anyway, so this is what it looked like when we're cleaned. I probably today would have smoothed the margin a little bit more, not so sharp there on the first premolar, rather. Now, I'm going to show something very, very strange. And no, this is not a mistake. When we do this procedure, what I will typically do after we've removed biofilm is I will etch separately the buccal and lingual surfaces of the teeth, taking as best care not to etch any dentin at this point. So, in other words, we'll take the etch, I'll run it all across the buccal with no matrix, no separation, no even wedging. I'll run it for the allotted time by the manufacturer, and then we will rinse out, typically about 10 to 15 seconds. And then what we do next, and this is just for those who are quite familiar, is that we'll try to fit a slightly larger wedge to further increase the amount of separation that we have available for the technique. In this case, we cannot get the wedge through, and this is the extra large diamond wedge coming in, and that's the HD matrix, the BioFit matrix. So I had to go back to my original large wedge. And again, I apologize, or not again, but I'd like to apologize for some of the quality of the pictures. This was done a few years back through the operating microscope. A lot of times when we're doing these cases, we're using the operating microscope. So this is what it looked like when it's seated. This is with the ring in place. And just now, very, very quickly, to show you what is going to be the technique we are going to use, because I still get a lot of questions, especially from those who have not taken the course, about how do we actually injection mold properly. And so again, it's a 3-step procedure, and it's very, very simple. And to make it even more simple, this was a demonstration done by my mentor, Dr. David Clark. And what he did is he he's going to take some bonding agent. He's going to use some food grade coloring, and he's going to show you where the materials should flow, and you'll see. So the first thing he did is he dyed the bonding agent orange. So he basically played food grade coloring into the bonding agent. And this is just done for demonstration purposes. Then he took flowable and he dyed it green. And then you do your protocol, which is you do your, again, when you, especially if you have caries, you acid etch. We're doing 5th generation. So you etch it and then you bond it as any standard protocol that you're using. And then what you're going to do is you're now going to re-wet the cavity. And this was a questions I had received a lot from the other webinar, but you re-wet it, you air thin it, but very importantly, you do not cure it. So basically you apply it and you're using it somewhat like a surfactant, just as a wetting agent. But again, do not cure it. And again, this is where we see the most mistakes. Then right into the into the bonding agent, you place your flowable composite. And you can see what's happening. As you're placing the flowable composite, the bonding agent, which is dyed orange, is starting to become displaced. And you do not cure your flowable composite, because at the next step, what you're going to do is you're going to use heated paste composite, and you inject it directly. Now, this is what I wanted everyone to see, especially towards the bottom of your screen. You can see that during the application of the heated paste composite, the orange and the green is being displaced almost uniformly. So the plan with this technique is to provide the paste material that will then displace the weaker bonding agent and flowable composite. And you can see again that it's almost coming out uniformly. So that's the technique here. So in our example right here, we're going to wet with the bonding agent. Then we're going to use heated flowable, followed by heated paste. And then adapt it with either a microbrush or a rubber instrument. The point here, again, is that it is not advocated, although many do it, but it is not advocated by the instructors at BioClear that you actually place any occlusal anatomy. And I know this is where there is a lot of pushback, and that's okay. But we teach it, and you will see that we do not teach it any anatomy. We just place it, adapt it, cure it, and smooth it. And now if you look here, this is after removal of the first matrix, and you'll notice the amount of flash that is present. Now the flash, though, should only be present on the buccal and lingual surfaces. So this is actually quite good. This is a very successful application of this material, because we want the margin actually to be pushed out to the buccal and lingual. We can talk about that for sure, but perhaps after Pantelis. And I want to show you here, this is another example of a case I did, and this is immediately after injecting the composite. Simply, I removed the ring, I removed the matrix, and then I removed the wedge. Now, as you see here, in this area right here, this is my margin, because again, we are not filling boxes. With this technique, what we are trying to do is we are trying to fill the tooth. So is it wider? Absolutely. The other thing I want you to see is if you look at the occlusal, you can see that there is the formation or the beginning of a formation of an occlusal embrasure. And sometimes that is quite difficult to obtain with a Tafelmayer, though, of course, there are many skilled clinicians who can do this. But I want you to look at this. This is something that's referred to as the tooth resin interface. And you should not be able to see a very clear margin, because we are not trying to create a margin. In other words, we don't finish to the box. We finish the tooth out to infinity. And that's, again, the tooth resin interface. And yes, can be quite wide. All right, so anyway, I'll very quickly, we do again the other one, same thing, and look at where the excess is coming out here. Now, I want you also to take a look at the resultant shapes. You can see that they're quite wider than the original, and that perhaps may be better at deflecting any type of food, because there was a slight misalignment or malalignment of the teeth. But again, I want to stress that this is quite good to have this much excess, but just also note that the excess is coming out only to the buccal and lingual. In other words, there is no gingival excess, and that's controlled by the matrix and the wedging. Anyway, this is what it looked like. Pictures are terrible, but you can see the contour. And this is what it looked like after 4 years. Now you can see, or 3 years, you can see that there is no anatomy placed. You can see that there's favorable tissue response with the slightly wider contours. So again, I picked this case especially because I knew it would hopefully give some questions or angry comments, and that's okay. But these do tend to hold up. Now, is this a bit grayer, speaking to what Pantelis was talking about? And the answer is absolutely, because this is done with a bulk fill composite. They've changed some of the formulations now, as I understand that they actually can opacify upon curing, but it is a bit gray. Now, is this objectionable to the patient? And I say absolutely not. They're quite happy with it, and it's functional. And I would say that it may put the patient in quite a good periodontal situation, because of this premise that I talked about last time. And just to finish with this little radiograph, and this was a patient in her 80s who had a gold crown and some composite repair. But you can see with the adaptation of the matrices, you can get a very good, smooth, and more importantly, you could get a physiologic contact, which I think would be of better benefit. Here's another case on the bottom, just to show you that principle that I spoke about in the first one. And that's simply that we talk about the value of pink and white aesthetics, but don't forget the value of the gray aesthetics. So with that, I'm going to turn over, unless we have questions, to Pantelis. And Pantelis, sorry to take some of your time.
Thank you very much, Arthur. It was absolutely amazing. Should we finish this lecture now?
No, the best is coming. The best is coming.
I think we have questions from Pantelis, please.
Okay, there's a question. What would be the light curing protocol for injection molding technique? Would you repeat a few more times of light curing all around, hoping to reach the composites at the full depth of the cavity?
Yeah, thank you, Alex Nina, for that. That's a great question, and one that I was trying to not touch on because I knew that the other gentleman would be talking about polymerization. So there is several protocols we use, especially for deep carries. So in this case, it was cheating a little bit because I took a case that was very shallow by comparison. But in deep carries, what we do is we will actually we have a gauge. It's called the go no go is what it's called. Developed also by Dr. David Clark, and basically it shows you that at a depth of 4 millimeters you are safe to cure. But if your box exceeds 4 millimeters, you do have to build up incrementally. And I'll be happy if you want to contact me about the specifics, but it's done in 2 stages to make sure that you have a maximum of 4 millimeters to cure. Also, the clear matrix allows you to cure from all angles and especially deeply. And again, it is a bulk fill.
All right.
So we should proceed now, huh?
Yeah, I'll answer the other questions. Let's get to Pantelis. I want to make sure he has time to do his. And I'll answer that. Gohar, I will answer your question for sure. And I'll talk about the,
All right. So let me first comment that I'm going to repeat, let me see, Hassan. Okay, I'm going to repeat my comment when I will present this particular case, which I chose to present to you today. But let me first apologize that for my Greek on my slide. This because this has been set up on the fly, so you can all understand that we had no chance to review our slides and see this thing. So let me tell you that this is a date. This is September 9th at 2010. Those were the times where Greece was entering into a huge financial crisis, which actually changed the way not only that we were living in Greece, but also the way that we were working in our private offices. Why? Because patients starting to ask for more cheap solutions. So in any case, before this date, I would treat this particular case totally in a different way. So this is where I started to explore my ways into the bonding and into the potentials that a good and accurate bonding can provide us. And this is where my whole career has changed. The route of my career has changed. So this is the case of a 25-year-old guy who presented in my office in this kind of situation, and he asked for a solution. Of course, the first thing that I was able to offer to him was an implant. This was my point of view at the time. Of course, due to the financial crisis, little people had the financial ability to place an implant. So I told to him, okay, let's make something in a temporary matter, and let's see let's address this. Let's postpone the treatment for the implant. Okay. So what I did in 20 minutes, I just placed with no rubber dam, no further procedures. I just put some single shade, complete total buildup. So I'm very sorry about the quality of this picture and the quality of this restoration, but this has been done very quickly and just to address a problem which was present at the time and to postpone the treatment. I saw this patient back at May of 2012, 2 years afterwards. You see that no stains initially applied, but the nature had took care of the natural staining of the tooth, so it has a more yellowish and staining appearance, but yet it's on the place, on the tooth. So it's functional, it's working actually. And this was the time when it fell off. This was at 2015. Excuse me, this was not the same case. I will just pass this slide. So then I saw again this patient at 2015. And this was the situation. I mean, we are 5 years after the initial treatment, and we took no specific care of the initial treatment, and we were able to gain 5 years of this tooth remaining in the mouth. So then I thought, okay, if I have 5 years with that kind of solution, why don't I start and treat the case properly? So that's the buccal side of the restoration. And this is the isolation which I managed to have. You can see that I have added some liquid resin to block the leakage from the palatal side of the restoration. And at the left side of your screen, you can see that I used the only type of post and core which I actually apply in my patients. This is
Excuse
called.
me, Pantelis, there is a
yes.
question.
Yes.
Was there root canal treatment before or
Sure.
after? I mean,
Sure,
when
yeah.
did you do root canal treatment? Did you repeat the root canal treatment? Maybe the question is like that.
I did not repeat the second time the root canal treatment. The root canal treatment was done at 2010, and it was stable for more than 5 years. So I had no reason to touch the root canal treatment. It's stable. Okay, so this is the kind of the post which I use now. It's called Everstick. It's being distributed by GC, and what it does, it's actually there are fibers, unidirectional fibers, which are pre-embedded in a partially polymerized composite core. Okay, and you may feel it. It's like rubber. And you can do this. You can carry it with a surgical scissors, and place it inside the root canals in the same way that you do when you are doing some lateral condensation of the gutta perca when you're obturating the root canals. Then you can light cure it, and then you take it out and you light cure it again. And once you have light cured the material, you have a customized post which can be used. In this case with some flowable. And I used the extra material which has left from the same core to create a scaffold where I could use keep my restoration builded on, and then I used some pre-curved matrix to build the proximal surfaces and on the other side one by one, and then I went on after I built the proximal surfaces, which in the same way that Arthur was showing us before. Then I started to build the cusps one by one. And this is called the cone technique, and the cone technique has been suggested from a dental technician back in the past. His name is Thomas, so we are referring to this as Thomas's technique, which actually was suggested for the Waxeps. When you actually place a cone, you may be able to place the top of the cone on the same side, on the same place that is going to be the top of your cusp. So if you see right here, because I'm having the layering approach, I am building the dentin cone, and the dentin cone is a slightly shorter than the tip of the cusps of the adjacent teeth. And if you see it on the occlusal side, the top of the cone it has to be placed on the line that connects the top of the adjacent tooth as well. So
Excuse
in
me,
that way,
Pantelis,
yes,
sorry,
yes.
there's another question asking if
Yes.
you had removed the secondary caries or not.
First of all, I didn't have any secondary caries. The tooth was black due to the whole history that it was bearing after. But once you have some solid and hard dentin, then you don't have to remove anything. I have to tell to my friend that there is a classical paper from 1968 which called a deep study on carious lesions. It has been published by Shovelton, and according to this paper, when we clear the caries from a tooth, from a tooth which is infected by caries, at 74 of the cases we do not completely remove the caries. So we do not have any clinical leads to guide us on when to start drilling. Okay, so once you have hard substance, hard dentin substance, which you judge that you can apply pressure, can bond on, then go for it. Don't look about what caries is and what stage of the caries you're into.
What about the
Okay,
disclosing agents that Arthur is using?
Which agents?
Disclosing agents like.
Oh yeah, this is a tip actually which I just learned those days from Arthur. I never used it, but I will start to imply it from now on. I can certainly say this. It's gonna be good. Yeah, I think it's gonna be very helpful, and I liked it a lot. Okay.
Okay, please.
So I'm proceeding. So I'm placing the cone exactly where the top of the cusp want to be. The same goes to the palatal cusp as well, and then I'm building the enamel shell. And then again on the biomimetic approach, I'm building the dentin on the top. I had the luck that the adjacent teeth had some white lines, so I could cover the discoloration on the cervical area with some white opaque flowable resin. And then I built it again and I polished. And then I stained. Okay, this is not important. We do that in Europe as well, but we like it. It's not important for the patient. It's for our own ego. And this is the case. And I have to tell you that I'm following up this case up to now. It's there. It's as you see it. I don't know if I have any picture next to it with the follow-ups. I think I was. No, that's the other case I'm going to show you. Okay, I'm going back. Okay, so at this case, we were able up to now to have plus 10 years before an implant placement. And if you think of if you think of it, that this guy was 25 at the time, he's now 35. I mean, how many years will an implant serve to him properly on the posterior upper jaw area? I don't know. I think we have some literature about it, and there is a big discussion on what we consider as a failure and what as a success in the implants. But we have included to our successes the loss of the bone crest for exactly 0.2 millimeters per year. So if you add this over 10 years, you can imagine that in several implant cases we may had some exposure of the implant of the cervical of the implant and still be considered as a success. To me, as long as we have a root, an intact root which we can use, this could be some treatment option. I would like some comments on from you guys for this case as well.
Yeah, which materials do you use for staining?
I think it was from IPS Empress the ochre.
Okra.
Yeah, the ochre from the IPS.
And we
Arthur?
don't have other. Yeah. Arthur, do you have a
Do we
question?
have any?
No, not yet.
Not yet. Okay. So, this is a case which I treated a couple of years ago, and this was a patient at his early 30s. The main cause of this situation is his dietary habits. He used to have a frappe. Let me show you what frappe is. Let me show you. Is it on? Yeah. This is a frappe. Okay. So
Can you show it again? Can you
all
show
right.
it again?
There you go. This is a frappe.
Sorry. Here.
Yeah.
This is frappe.
Okay. Yeah. Okay, so this is a kind of Greek habit. It's a kind of cold coffee which we actually are drinking, and we drink it like for 3 or 4 hours. Okay, it's a cold coffee. This guy used to drink his coffee with 3 spoons of sugar inside, and he used to keep it on the buccal corridors, because he liked the sense of the sugar and the coffee combined on his buccal corridors. So if you just take a note on his situation, take a look at his number, his canine, his left canine. I'm sorry, it's a mirrored image. You can see it on the right, but take a look on his left canine, number 23 in Europe. Is completely missing all the buccal surfaces. As well as his all buccal surfaces are heavily damaged. So this is the situation, and this is the lateral views of the situation. Okay, so you may see on your left side of your screen how big the damage is, and again the financial.
There is a question,
yes?
Pantelis. We have a question.
Sure. Yeah.
Was build-up is best option for the case? I think it's for the previous case.
Build-up is the best option for the case. All right, is the best option. It's not the first option that I suggested. I was telling this. Is it the best? At the time, at 2010, to me, it was not the best. After I've done this case, and after I changed the way I'm working it at my office, and after I having as after the review I have in my patients, this is the actual number one and only suggestion which I do in my patients. Now I treat my patients every day in the same manner, in this way. So I don't know if I answered correctly. There's yes.
There's another question.
What do you think about the ortho extrusion for more supragingival tissue? That's a very good question, actually. Okay, so when we do, there is another option as well, not just the ortho extrusion. There's the option of the margin relocation by surgery. I mean, you can just drill some bone and have some ferrule effect. Okay, but well, this is important when you want to do some conventional crown. If you want to do some crown lengthening, for example, if you want to build some conventional crown, that's the option. That's one of the options. Okay, But when you want to bond something, you don't need any extra. You don't need any ferrule. Of course, when you thinking about the ortho extrusion or the crown lengthening, you have to take in mind that you need to have minimum root length the same as the crown height. I mean, you cannot have a bigger crown than your root, then it's going to fail. So you have to take all those factors in mind before your decision making. And I don't know, it's much less favorable to extrude a tooth, or to extrude a root, or to make some crown lengthening. Much less favorable. It creates much bigger levers. I don't know if you can understand the rationale I'm thinking. Okay, do you agree to this? No comments.
We need to ask Mujgan from
Yes.
Turkey.
What do you think about the ortho?
Maybe she will reply.
Okay. So let's go back to that case. The hardest thing, I mean, the option to that case was quite straightforward. It was direct restorations. So what was the most difficult part of this case? It was that the cervical margins, the cervical lesions were going deep down into the gums. So we had to fight so much to gain some access and to be able to place the rubber dam. You can see that here was a metal fight actually. But here I placed the two clamps, the two before clamps. The one was placed vice versa, so it can be, I can be able to enter through the clamps and to fill up those spaces, and then this is the etching. Actually, this is the bonding. Then I had to fill the number 3-4 tooth. Okay.
Are they freehand or did you use any
Yeah,
matrix?
those are freehand. Yeah, those are freehand. Then I removed the before clamps, so I was able to fill the number 3-6 tooth. And this is the direct result. This is the one quadrant. So we went into big appointments, and we were treating each quadrant on a separate way.
May I ask a question?
Yes, of course.
In the previous photo, can you go back, please?
Of course. This one?
No, the previous one, the cavity prep.
The cavity prep, okay. This one? No.
Are the margins extending below the CEJ? Do you have enough enamel cervically?
Yeah, I have enamel. You can see it, yeah. I was lucky enough, but even if I had no enamel, I would go to the same approach as well.
And what about the teeth are vital, yeah? All of them?
Yeah, all teeth are vital, except the premolars on the upper jaw, which I will show you separately.
There is a fistula I've seen in the upper jaw. There is a fistula.
Yeah, exactly. Yeah. We had to do some root canal treatment as well.
But this approach requires good clinical skill. It's not for everybody to isolate like this, because I think
Serhat, that skills
are, like this.
I think that skills is something that you are gaining when you fight over a case. I mean, I really was not able to say at the start of at the beginning of this session if I will be able to isolate all teeth, but then I start fighting with the clamps and the rubber dam and everything. Okay, so
and beautiful pictures, by the way.
Thank you very much. I'm improving my skills in photography lately. Okay, so this is the recall after a week. You can see the response of the soft tissue, which is very good actually, and then we can move to the other side, which where the situation is less severe.
Mm-hmm.
So we have repeated the same stages again, and then during all those procedures we were doing the root canal treatments on the premolars. Yes, Serhat?
Your upper. Sorry, I didn't say anything.
So
Please.
yeah, we're going to the upper premolars, and we have performed the root canal treatments. This is on the 2-4. It's glass ionomer cement to keep the situation blocked while we were not able to place anything there. So what's the option, guys? What would you do? Can I ask you?
To us. Can I say first?
Yeah, sure.
I would extract first premolar.
Yeah.
And but you will, and the second one I will place root canal treatment after fiber pores and crown it. And a secondary option is forced eruption for upper premolar, first one,
Yeah.
and then again fiber pores and crowning.
Okay, my initial suggestion to this patient was an implant supported prosthesis at both sides of the premolars. Yeah, for both.
Ah, okay.
Yeah, just a single implant, but for both premolars. Okay, because we do not have the space on the bone. Okay, but of course, for financial reasons as well, he was not able to do so. But what are the options actually? Do we have an option for a post and a crown here? A conventional
Arthur?
way?
What do you think, Arthur?
And this one, I mean, depends what you would see on that second premolar. But for me, to be honest, that first premolar doesn't look like it's very savable.
Now it's difficult, yes.
Let me answer to that. Okay, do we have the option of cast post and some crowns?
Can I show this full screen because it's a beautiful photo? Wow.
Sure, of course, sure.
Wow.
Go ahead. Okay, do we have the option to go for?
No, can you repeat the question, please?
Yeah, do we have the option for going to a cast post and a crown over the top, and a conventional crown, MPF?
I need to see also the X-ray.
Oh, sorry, I don't have it on this presentation. Actually, it's on my in my office, so it's not available. Maybe in private message as well.
Length of the root, and maybe you can do surgical crown lengthening plus because you don't have enough ferrule.
Yeah, Serhat, you have to create some ferrule. We don't have any ferrule, so the option as is to make some cast post and some crown, it's a no. Okay, you have to create some ferrule, right? So what's the other option? We all know about the endocrowns, right?
For this case, yeah.
For this case. Okay, now this was a revealing picture. Okay, but let's see what literature says.
Okay.
It says that for the premolars, we have a survival rate of 70% at 5 years. For the molars, we have 95% survival rate for the 5 years.
Can you repeat? Are they for endocrowns?
Yeah, for the endocrowns have survival rate of 70%
for premolars.
For the premolars, for the 5 years survival. Okay. The molars have 95% of survival. All right.
So it's better to use endocrowns for molars when compared to premolars.
Exactly. When you have a molar, then you have a favorable situation to do some endocrown. All right. But in this situation, you have 2 roots remained and 70% for survival rate at 5 years. Okay, for each. So what you can do, you can transpass the situation to a molar. So you can do some splinted premolars. So you can increase the survival rate of your work. But if you do so, because this is composite, actually, this is lab fabricated restorations. Those are composites. If you do so, then you have to have some huge connector in between the teeth, and this will not be favorable to clean for the patient. Okay, so what we can do? Excuse me, I have no picture on this, but I will describe it. I sent to my technician a piece of the post which I showed you on the previous case. So he integrated the post, the Everstick post,
Mm.
on the connector inside these composite restorations, and in all this is going to be functioning in a single as a single restoration. Okay, and then you just bond it to the roots. It's easy. The most difficult in this case is to isolate. All right.
Exactly. Yeah.
Yeah, if you can manage to isolate the case, then you can manage to bond. If you can manage to bond, then you don't need no post, not anything. All right.
Mm-hmm.
So this was
Pantelis,
the
do you have a
yes.
film of that by any chance? Post-operative film or recall film?
Yeah. Just wait and see, please. Okay, it's been now 2 years. I have 2 years recall on this. Okay, let me go through the entire case. This is the view from the buccal side. You can see the canine case, which I was telling you. This is some. We have some leftover of the. I'm missing the word right now. Okay, I just cleaned this up. This one.
Pantelis,
Okay.
I
Yes.
think we have a question, and you'll see in the screen.
Sure.
You'll
Let
see
me-
now in the screen. Do you think that first? Please see on the
Do I
screen.
think-
I'll say it for you. Do you think the
yeah.
first build-up failed because you didn't use a fiber post, and the second
No.
time you will have success due to the type of post?
No, it's not related to post. It's related to the isolation. Only the isolation. If I was performing the same procedure again, maybe I would use a post, maybe not. In some cases I do, in some cases I do not. It depends on the occlusal scheme. If I have a flat occlusion, I do not use any post. If I have some occlusion with deep fissures and high cusps, then I use a core. Okay, this is what, because I want to change on how I distribute the forces, the occlusal forces into my material, and this is only the way. Okay, this is only my only criteria on how to treat a patient. Okay, so the post is not needed actually. The isolation is a must. Okay. So let me go. This is the other side. This is the other premolars. This is the right premolars. Here we have a more favorable situation. This is the same procedure actually, but then we had to bond again, and we had. Let me go back again, and then I treated the caries directly because this was the only time when I had the chance to do so. All right, we have the enamel etching. Here I treated in a separate way the cervical area of the first premolar because it was not favorable to drill down to include it into the indirect restoration. So this was a direct cervical restoration, and then I etched. This is the bonding procedure. The bonding I always bond using conventional composite heated. And these are the occlusal contacts after the procedure. And then we went to the anterior area to treat the aesthetic issues. I was worried that if I was starting from the aesthetic area, that I would miss the patient, that he would never be back. So this is why I just left it last. Yeah, because this has to do with on how you judge a patient on his compliance. But after I have to say that I only treated the patient only when he managed to get rid of the sugar in his coffee. And only when I was sure about it. Okay.
Beautiful.
So
Pantelis, can you just talk
Yes?
real quickly about your favorite types of clamps that you're using? Because I know this is not about isolation, but these are some pictures you put up. Would you mind? Because I'm sure people are going to ask questions about your favorite type of isolation.
I
clamps.
have no such. I'm sorry. I have no favorite. I have a collection which is, I would say, huge collection. And I'm trying. But when I have situations like that with the just a root remained, then I first go to the brinkers before clamp, and I
Pantelis,
try
we have a
to stabilize
question,
it.
but excuse me.
Yes,
Did you
yes.
apply bevel to enamel margins? I don't know
I
for
don't. I
posterior
don't
or anterior.
always. Yeah, the thing of the thing for the beveling is quite wide. I would say that I'm applying beveling not to every case, and I do not use a single kind of beveling.
What about
What
class 5 cavities where you don't have enamel margins cervically?
this is
Maybe
a
this
case
is
where beveling may be needed. Yeah, this is a case where
just
beveling.
increase the retention, maybe. Yeah.
Okay, into anterior, actually, let me. Okay, this is the picture of a 2 years follow up, Arthur, where you asked. Okay, this is 2 years. You may distinguish this. Okay, so for the anterior region, it depends on the optical properties of the material which I use. If I will do some classical beveling or the S-type beveling, this is dependent on the translucency of the material, but this is a complete different lecture. So maybe I should pass this question for for the future
There is
sometime.
another question, Pantelis.
Yes,
What if the
yes.
patient asks for first for the aesthetics done? If the
The
patient
patient,
asks, then you
the
say no. Kindly say no.
yeah. Actually, the patient, this is what he came for. This he
Not for
came
the
just for
posterior.
the. Yeah, I have lots of patients which are only asking to be treated on the front, on the anterior zone, but
This is for,
it's up to you to suggest the treatment. I don't follow this kind of. I always start the treatment from where I judge that should be. So, and you all may see that there were so many severe issues in this case which I had to address. So I would say no. Okay. Guys, do you have any questions? This is the recall in 2 years, Arthur, which you asked for, and I'm following the case. I'm in contact with that patient, so I can assure you that it's up to now. It's like this, and you all can see that you have some heavily staining on
yes.
on the.
It's not due to coffee, yeah? It's not the coffee stain.
It's probably due to coffee. He's a heavy smoker as well. You can see some inflammation on the soft tissues, but this is the best I can take out from this kind of patient. So
you got everything and more. That's a great job.
thank you very much. Any kind of comment I would love to.
I think we don't have the questions. So have you finished all your cases?
Yeah, that was from me.
So
for those who are not, we have one.
There's one question. What?
Go ahead.
Take the question in the screen. Why heated composite, not resin cement? Why did you use heated composite, not the resin cement for your for diluting?
Okay, because of the mechanical properties of the composite related to the resin cement and the hydrolytic stability as well. I only wish to have a single bulk of restorations over my teeth, so I don't use any intermediate materials. I don't use any posts except of such cases which I shown you. I try to have a single bulk. So if I am constructing this kind of indirect restorations over a composite, then using a composite is going to be working mechanically identically or similarly to the restoration. So this is the main way, the main reason. Excuse me.
Okay. And Pantelis, do you mind, just for the audiences who are not familiar with an endocrown, can you just describe what that is?
What's the endocrown? It's a term which is not actually okay. It's when you are missing the major part of the crown, of the anatomical crown of the tooth, and you do not have any remaining walls to build on, and you are not using post and core, then you have a complete bulk of volume of crown, of artificial crown bonded onto the root. To construct such an construction, usually we are trying to use the interior pulpal chamber walls to be bonded on. Okay, so this is why on the molars we have a bigger chamber, bigger pulp chamber, and we're able to have more volume, more surface to bond on, and this is why we have so bigger rates, because of the surface, of the active surface we are able to bond. So basically, this is an endocrown. It's not classical prosthetics like PMF, but it's bonded prosthetics. Is the future of the prosthetics, in my opinion.
Okay, thank you. And I think we have one more question.
Yes. Can I show?
If we're using composite padding, how you make sure
Yes.
light goes through the crown? If you're using composite padding, how you make sure? Yeah. Okay. How you polymerize, actually. Okay. So if you consider that you have buccopalatal distance, like 5 millimeters, if you consider what's the size of a crown on the buccopalatal aspect, you have some like 5 millimeters. If you light cure from the buccal, you have 2+ millimeters of depth. If you cure from the palatal, you have 2+ millimeters of depth. You have to use some translucent shade of conventional composite. I use enamel shades with a translucent value, and then you have to cure from both sides, and then you have to cure again, and then when you finish curing, you have to cure again. Okay,
and
so,
again.
yeah, actually, you have to burn down the tooth, the teeth with.
And you need to use 2 or 3 light cure device.
Yeah,
just to be sure.
exactly.
And
Exactly.
another question.
Multiple devices at the same time.
Yeah. What about the deepest part of endocrown?
Excuse me, Serhat, don't do this on a vital tooth, okay? On a vital tooth, you're gonna be having necrosis, okay?
Yeah, sure. But what about the deepest part of endocrown?
What do you mean? Inside
this question from the friend.
Yeah.
Is it possible to cure better in the deepest part of endocrown?
No.
Like a molar?
Use a bulk fill.
Use a bulk fill.
Yeah. It's an option. This is a very good use for the bulk fill.
Because it's translucent?
Yeah, it's translucent and has a bigger, highest depth of cure and less shrinkage. So
and you would not want, sorry, go ahead.
Yeah.
And you would not like a dual or self-cure in this application?
I don't like dual. I don't like dual at all. Why? Yeah. Okay. There is a chemical. Okay, dual cures do not work in acid environment. So when do we have acid environment? When you have some acid adhesive, or when you're not very well, you have not rinsed the acid etching. So you always have the potential that the chemical polymerization does not occur properly when you have acid environment. And most of our materials, the adhesive materials we use, are acid. So this is why I do not like, mostly this is why I don't like the dual cure. But if you start to use a system, I mean the same adhesive and the same manufacturer and the same dual cure, then go for it, because they have fixed this issue. Okay, so for example, if you're using Panavia, use the adhesive from the Panavia. If you're using the Colten, which has a dual bulk fill, use the adhesive from the Colten. It's okay, it's compatible. But if you are using a different adhesive with a dual cure, then you're running into the possibility that you have not compatible materials, and you will not have any polymerization on the chemical phase.
Thank you.
And there's a question about the bonded floss technique. I think it's
bonded.
The question is to me. I think.
Yeah, probably.
I
Yes.
mentioned in my part, because in short, you're already using a floss and you're drinking too much frappe.
No sugar, not sugar inside.
Not sugar, yeah.
I told you it's 2 hours procedure. The frappe.
Frappe zero, yeah. Okay, the
I
bonded
think there's
floss,
yeah. Oh, sorry. Go ahead. Go ahead.
okay. I usually use floss just to retract the rubber dam, and I
Yes.
know that when you just floss tie the floss, when you tie the floss, I mean when you maintain a floss tie double strand, means it's really tight and doesn't release its tightness during your work, and plus you add some you apply additional bonding material or flowable, so you just stabilize it and doesn't move. So you're sure that it will not move mesodistally or cervica incisally. So you're sure that it's stabilized. And just fixing the tie of your floss, you're just guaranteeing, and it works like an rubber dam clamp partially. But I found out, discovered in my clinical experience, that it sometimes creates some smaller extensions around the neck, around the cervical part of that you're working, and you need to be careful about removal of even the small extents of these resin material. So when you are using bonding agent or the flowable next to your floss, just be sure that you're scaling, or just check with the probe not to remove and not to leave there any excess resin material.
I see there's one unanswered question just going through.
Really?
There was one. I got it from Gohar. He had asked, can we remove the biofilm layer with the Profi scaler? That's mine. Okay, so that's so the answer to that is you can, and I believe that had to do with when you're trying to etch the buccal and lingual surface of the teeth or trying to clean it. A scaler can work, but that's going to take a long time, and I'm not quite sure you're going to be able to get into the deepest recesses of the interproximal area. So you can, in answer to the question, but I would still recommend you use some type of air abrasion unit. And I think that's the last new one. Thanks. Okay.
Right. So I think we have completed. Yeah.
Yeah, guys. Thank you so much for that. Fantastic presentations, guys. It was a pleasure. I learned a lot, learned so much here. Thank you, everyone, for your questions. We will see you here tomorrow, 1600, 10 a.m. Eastern Standard, with another edition. Serhat, who do we have tomorrow?
Okay, let me pronounce well. Let me see. 1 second, because it's an 1 second. Tomorrow we have Carlos from Portugal. Prof. Carlos Falco from Portugal.
Okay. That's
He
going to
will
be
be lecturing about digital design and manufacturing in natural teeth.
Okay, guys.
Digital design and manufacturing in natural teeth. Okay.
Perfect. So until tomorrow, everyone, please stay safe. Be careful, and we will see you tomorrow, guys. Bye.
Okay. Bye-bye.
Bye-bye, everybody.